I am an improvement advisor with Comagine Health, and I'm a member of the opioid work group. Just some housekeeping before we move forward. Please type your name and your organization in the chat. You can certainly submit any questions as well. We're hoping to have a few minutes at the end to field some of those questions, and please feel free to do that, or if you're having a logistical issue, go ahead and chat in. Alberta will be managing that. Please keep your microphones muted, and after, when Sarah gets started, if you'd like to also turn off your camera, that would be great so we can focus on the presenter. I want to talk a little bit, oh, and also this presentation will be recorded, so if you have interest in sharing it with your colleagues, um, we would like you to do that. And we are testing the idea of having a conversation in the beginning of next week. And we'll be inviting you, sending you a link to an office hour just to get to know you better, find out about your best practices, and please join us for that. The mission of Comagine Health is, together with our partners, we work to improve health and create a better healthcare system so that people and communities will flourish. And for the overarching goal of the opioid work, our goal is to decrease opioid use and improve behavioral health outcomes. And we hope that this Quickinar will help us achieve that goal. I'm happy to introduce my colleague, Sarah Phillips, who's a Senior Improvement Advisor at Comagine Health. Sarah is a registered nurse, a certified professional in healthcare quality, and holds a master's in business administration. Take it away, Sarah.
Well, thank you to the two of you for joining us. We have a small audience today, but I think I'm actually happy about that. As Maria mentioned, this is our first pilot of our Quickinar session. So just so you know, Quickinar is a 20-minute presentation. We're going to go quickly through things, and then we will again, be having those office hours where you can go deeper dive if you would like to later on. I want to give two disclaimers before we start talking about the agenda. The first is that presentation is no way meant to say that we should never use opioids. Opioids have a place, and there are patients that need that type of medication for pain management. This is really focused on identifying some of the options that are out there that are alternatives to opioid pain management because of the risks associated with opioid use. So first, we're going to talk a little bit about the case for alternative pain management. Then we'll talk about the multimodal pain management strategies that are out there and what that is. And then we'll do a little bit, of a dive into the medications and therapies that are out there for acute and for chronic pain other than opioids. First, we need to understand what we're talking about. So the first thing we need to know is the definition of acute versus chronic pain. Acute is something that occurs and it lasts less than 3 months. It's a result of tissue damage or potential tissue damage. So think of a patient who breaks a bone or has an appendectomy. These are it has an identified cause. It's the body's response to some type of an injury. This type of pain does diminish with healing and usually responds very well to treatment. Chronic pain is very different. It's something that lasts a lot longer than 3 months, and it can be years up to a lifetime. In and of itself, it's considered a disease. There's probably an underlying disease process, or there may not be. There may be no known cause, no known injury with chronic pain. And it usually persists beyond the expected healing time and even despite treatment. We tend to think of opioid misuse disorder as something that happens with younger populations, but there are several articles and several research studies that have been done now focusing on the elderly. And when I say elderly, I mean patients above 65. One of those articles, there's a quote here from it, that perioperative opioid prescribing has been associated with persistent opioid use after surgery. And the second one I thought was really interesting. This was a large retrospective study comparing the elderly patients to younger patients. At 390,000 were reviewed. And out of that population who underwent minor ambulatory surgical procedures. So this isn't something major. This is, they had something very minor done. Those patients that received opioid prescriptions within 7 days of discharge, a year later, they were 44% more likely to continue using those opioids than the other group. So this is something that affects our elderly population on an equal, if not more so, basis. So why? Pain in the elderly can be compounded by both physical and psychological factors. If you think about the elderly, there are some underlying symptoms that could lead to that disability and that chronic pain. Things like fatigue and decreased mobility that comes with age. And then the psychological outcomes of age, where sometimes there's social isolation and depression associated with aging. And this all results in higher economic costs within this population. Sometimes, it's that person who planned to work to 70, but at 65, they just can't do it anymore and they have to retire. There are higher medication costs and higher costs for healthcare services and more social care needs when this happens in the elderly population. And it's really all the result of the chronic pain cycle. It starts with chronic pain, but then that results in I just can't get up and do things. So now I have decreased activity and I become deconditioned. That results in me having negative emotions. I'm never going to be able to get out of this chair and do anything again. And we start to avoid and withdraw from other people and from situations that in the past were positive to us. But with chronic pain, we don't feel comfortable anymore in that situation. Results in more distress, more disability, and more chronic pain, and becomes a cycle. So, what can we do about it? We can start looking at some multimodal pain management strategy. And really, all this is using a multidisciplinary approach to pain versus just the one of pain medication. Combines exercise, therapeutic approaches, and psychologically based approaches to pain. And it helps to decrease the pain and enhance function more effectively than just one modality. So let's talk about some of the medications that are out there that sometimes we don't think about. Tylenol, both by mouth or by intravenous administration. Post-surgical, this has proved to be a very effective pain management strategy. It really does act as effectively on surgical pain as some of the opioids do. The one problem that you will see with Tylenol IV is that it's extremely expensive. So if you're using this, you're going to want to transition that patient to medication by mouth as quickly as you possibly can once they're taking fluids and able to take things by mouth. Motrin also has an IV form. Um, there are some things that you can't use Motrin for. Patients with heart disease or factors for heart disease, if they've had GI bleeding, if they have liver disease, or if they've ever demonstrated an allergy to either Motrin or to aspirin, you would not want to use this type of therapy. But for patients without those factors, it really has proven to be as effective as some of the opioids post-surgically. Low-dose ketamine is also something that's on the rise. And it actually has a quicker onset and a longer duration and is comparable to morphine for post-surgical pain. Nerve blocks, of course, have limited use. This is something that you're going to use potentially a lot in the emergency departments, where you have maybe a broken bone you're setting or something like that. This is not something that we frequently use in surgery, but can be on smaller types of surgeries. And then steroids, topical, this is for your post surgical pain, um, topical, by mouth, by injection, things like prednisone and hydrocortisone. There are also non medication therapies that you can use for acute pain. And I think we've lost our focus on this in healthcare. Heat and cold, as you can tell by my hair, I'm not a young nurse. Um, this is something that we used frequently when I started nursing. And as I went through my career, I saw it used less and less and less, to the point that, toward the end of my career, we had a patient who asked for a heating pad, and we no longer even had them in the hospital. It is a good therapy. If you think about cold and you think about knee surgery, they don't just use the cold and the icing of the joint to decrease the swelling, it's also to decrease pain because swelling results in pain. Massage can also be used. Physical therapy is probably where you're going to get involved with this. And physical therapy and activity is an absolutely vital portion of pain control. Bringing them in, getting that patient mobile so that the muscle tension doesn't develop, which we know increases pain. These other therapies are used less often, things like low level laser treatment. It's actually used a lot by chiropractic, but not as much within the hospital settings, although it is on the rise, particularly with anesthesiologists who have pain management programs. They are starting to use this type of therapy on an outpatient basis. High intensity laser treatment also, things like TENS, electrical stimulation that helps reduce the pain at the site. And then the ones that we don't see very often, hypnotherapy and acupuncture. Acupuncture is actually thought to increase the endorphins in the studies that have been done on it. And that's the mechanism that decreases pain. Chronic pain, some of the medication alternatives. Gabapentin is an anticonvulsant, but they have found that it's very effective with neuropathy and chronic pelvic pain, and it's being used for that type of therapy on an outpatient patient with patients with chronic pain. Serotonin and norepinephrine uptake inhibitors like Cymbalta, they have demonstrated usefulness with fibromyalgia patients. Now, that is not an FDA approved usage of that type of therapy, but it has demonstrated effectiveness. So it's an off label use. Tricyclic antidepressants like amitriptyline have been used with lower back pain, nerve damage diseases, things like diabetic neuropathy, herpetic neuropathy. It's also very effective with patients with migraines. Um, so nerve disorders is really where you would think of that type of therapy. The the topical NSAIDs like Voltaren, this is something that's musculoskeletal. So osteoarthritis is where you would think this would be your most useful type of pain medication that's an alternative to opioid therapy. And then injections and nerve blocks, things like for lower back pain, herniated disc, trigeminal neuralgia. These can be very effective mechanisms. The alternative therapies that are out there are a lot broader for chronic pain. Things like radiofrequency ablation, and this is where they heat the nerve to the point that it's no longer capable of carrying the pain signal. Percutaneous electroanalgesia, things like the TENS. High intensity laser treatment has also demonstrated effectiveness. And then there are some that we don't think about very much. I always think of Dick Van Dyke when I think of yoga and Tai Chi. He swears that that's the reason that he's lived to the age that he has, because he didn't sit around. He kept very mobile by being very involved in Tai Chi. Acupuncture, we've already talked about. Things like biofeedback can be very effective. When you talk about the chronic pain cycle, that biofeedback can help you to block one of the elements of the pain cycle, and that can help to decrease your chronic pain levels. Relaxation training, and then one that has been used extensively within the veterans population and was actually developed there, is cognitive behavioral therapy. And this is really a program. This is your ultimate multimodal strategy, used a lot with patients who are currently using opioids and focusing on decreasing the need for those opioids. Starts with exercise. First element is maybe just walking, or maybe it's physical therapy. Any activity that gets that patient up and moving. But paced activity is the second element. I'm one of those people that if I have 10 things to do around the house, I'm going to want to do them all on Saturday. Well, this is teaching the patient that has chronic pain that you just can't do that. You have to pace yourself. If you have to clean the house, you clean one room. If you're starting a walking program, you don't start walking 12 blocks. You start by walking one and build up. Relaxation training, I think you can all identify with that. If you decrease muscle tension, you decrease stress, and that can decrease pain. And then there's cognitive restructuring, and this is where you really get into your psychology and where you would have additional therapists involved. Because they have to identify those unhelpful thoughts that I can't get out of the chair, I'm in pain, and start to increase their balanced thinking. And then behavioral activation. That's where they increase their engagement and start engaging in some of those things that are very meaningful to them again. Maybe it is walking the dog. Maybe it's getting out to visit friends. But you can see that this type of therapy involves a team to help that patient that has either become addicted or is experiencing chronic pain, and you want to put in a preemptive action to prevent them from becoming dependent or addicted to opioids. So what are we asking you to do? We went through a lot today. We didn't do a deep dive. We went very quickly through things. What we want you to do is look at your pain cycle, look at the things that you can do. That cognitive behavioral therapy puts blockades between those arrows and helps to decrease that cycle of chronic pain for the patient. We're asking you to start planning for change in your organizations. Implement a multidisciplinary team. Review the research, and that's all included in this presentation, and you can review it at your leisure. And then start to develop some protocols that will help you to start to manage pain differently with a team approach and not just go to the opioid for the very first option for every patient that comes into your facilities or your offices or your nursing home with pain. And with that, I will wind up. And if you have questions, it looks like we have just about a minute left. And I'll turn it back to Maria.
Thank you so much, and thank you for attending our first Quickinar. You will be getting an invitation for a follow-up conversation next Monday, which really we want to hear from you and hear where you are and how this material applies in practical application, what questions you have, and perhaps what best practices you can share with us. As we move forward, since many of us are living in a virtual world, we want to get to know you, and please join us if you have a few minutes. You don't have to come for the whole hour, but if you have a few minutes to say hello, we would love that. And our next Quickinar is April 1st, and it will be an introduction to the six building blocks opioid management through the University of Washington. We will have a facilitator from that group joining us. So be watching for that as well. And again, thank you so much for your time. Hope you have a good weekend, and we hope to see you soon.